Welcome to the Deep Dive, where we unpack complex medical literature to give you the essential insights you need, quickly and clearly. Today, we're digging into a persistent clinical dilemma, something that definitely sparks debate among gynecologists and reproductive specialists: how best to manage ovarian endometriomas in patients heading towards IVF.
It's certainly not a new topic, no. But the research keeps evolving, and it's really refining our understanding. It's challenging some long-held practices, definitely. We've sifted through the latest systematic reviews, meta-analyses, and key clinical studies. The goal is to help you navigate this really intricate decision with the most current evidence available.
Right. Our mission today is pretty straightforward: cut through the noise, clarify the evidence on whether to surgically resect an ovarian endometrioma before IVF, or, opt for a more conservative path. And crucially, we need to look at the impact of both the endometrioma itself and the surgery on ovarian reserve, and ultimately on those IVF outcomes for your patients. So let's start with a foundational question, one that still generates quite a bit of discussion. Does the mere presence of an ovarian endometrioma inherently damage ovarian reserve?
Well, this is still a highly controversial area. There are several proposed mechanisms you see. We're talking potential mechanical stretching of the cortical tissue, sure, but also the local environment. There's this idea of a release of toxic elements, free iron radicals, reactive oxygen species, creating this inflammatory fibrotic microenvironment.
A sort of toxic soup hypothesis.
Exactly. And some even propose a kind of burnout effect, accelerated follicular recruitment and then atresia. It's complex.
Okay. And when we look at the clinical evidence, does it actually support these ideas? Does it suggest an intact endometrioma takes a toll?
Well, some data does seem to indicate a reduction. For instance, a large meta-analysis, I think it included nearly 1,000 women. It found a measurable drop in serum AMH levels, specifically about 0.84 NGML lower compared to women with healthy ovaries or even other benign cysts.
0.84 NGML, that points towards some effect.
It does. And there was a prospective study, Kasapoglu et al., that found AMH levels declined much faster, about 26.4% over just 6 months, in women with intact endometriomas compared to only 7.4% in controls. So yes, there's evidence suggesting a direct impact isn't something we can entirely dismiss.
But is that the whole story, or is there conflicting evidence out there that challenges this view?
Not entirely accepted, no. And this is really where the debate heats up. Another big systematic review and meta-analysis looked specifically at unilateral versus bilateral disease, and it found no significant difference in preoperative AMH levels.
No difference, even with bilateral disease.
Right, which really challenges that idea that an intact endometrioma intrinsically reduces functional ovarian reserve across the board. And interestingly, Roman et al. Reported in one series that larger cysts over 6 centimeters were actually associated with higher preoperative AMH levels.
Higher? That seems counterintuitive.
It does. So this ongoing debate just highlights the complexity. We clearly need more definitive molecular and cellular work to really pin down the magnitude of any gonatotoxic effect. It's not as black and white as perhaps we once thought.
Okay, so the endometrioma's own impact is clearly still debated. But for years, the instinct for many clinicians, especially in fertility, was often removal, which brings us to, well, the elephant in the room: the surgery itself. How much does that impact ovarian reserve? This has been a major concern for a while now.
Oh, absolutely. And that concern is very well founded. Histological studies consistently show that endometriotic cystectomy, even when done by very experienced surgeons, often leads to inadvertent removal of healthy ovarian follicles right next to the pseudocapsule.
Right, that collateral damage.
Exactly. This iatrogenic damage, it can come from tissue handling, from tearing, and particularly from coagulation used for hemostasis. It's like trying to peel tape off tissue paper. Sometimes some damage is almost inevitable.
So how does that translate into measurable changes like AMH levels? Can we quantify that impact?
Yes, the impact is significant, and it's really well documented now. Systematic reviews and meta-analyses consistently show substantial drops in serum AMH. We're talking as much as 1.65 NGML after a unilateral cystectomy and over 2 NGML after bilateral procedures, usually within about 9 to 12 months.
Okay, those are not small numbers.
Not at all. To put it in perspective, that's roughly a 39% drop for unilateral and a 57% drop for bilateral procedures. And here's the critical point. These reductions seem to be irreversible. They remain reduced by an estimated 40–53% even 9 to 18 months later.
Irreversible.
That's what the data suggests. It's why the ESHRE guidelines explicitly recommend counseling patients about this significant and potentially lasting risk of reduced ovarian function after surgery. It's a key counseling point.
Wow, a persistent decline. You might hope that with increased awareness and maybe refined surgical techniques over the last, say, couple of decades, we'd see less damage now. Has that actually happened in practice?
Well, disappointingly, recent real-world data suggests maybe not. There was a study in Vernici et al., published just recently, May 2025. They compared ovarian response during IVF cycles after surgery, looking back over time. And they found the rate of severe ovarian damage hasn't actually improved over the last 2 decades.
Really? No improvement.
Apparently not. Absence of follicular growth was seen in 18% of operated ovaries. That's no better than what was reported more than 10 years ago. And the median number of follicles in the operated gonad was only 3, compared to 7 in the contralateral intact one.
3 versus 7, that's significant.
It is. It implies that despite, everyone being more conscious of the issue, the clinical reality of ovarian damage post-surgery for endometriomas is still substantial. It's a persistent challenge.
So the problem remains. Given that, are there specific surgical approaches or maybe hemostasis methods that seem to be less damaging? Any way to minimize this effect?
Yes, there is some nuance here, and research is ongoing. Studies suggest bipolar coagulation is more detrimental than non-thermal methods like sutures or sealants. You see about a 7% smaller decline in AMH with non-thermal methods.
Okay, so technique matters.
It seems to. And while the stripping technique is still recommended by ESHRE for lower recurrence, newer approaches are being looked at. Things like CO2 fiber laser vaporization or plasma energy ablation aim to be more tissue-sparing. Some preliminary studies show preserved AMH with these, but we definitely need larger trials confirming the clinical outcomes, like pregnancy rates.
Right, the ultimate goal.
Exactly. Ultrasound-guided sclerotherapy is another option being explored. It seems better for ovarian reserve preservation, but it does come with higher recurrence rates than cystectomy. And the combined technique stripping part, ablating the rest, is also showing some promise for balancing recurrence and reserve. So work is ongoing.
Okay, this brings us right to the core of the dilemma for clinicians and patients. Does removing the endometrioma actually improve IVF outcomes? Or does leaving it intact hinder success? This is what really drives the decision-making.
And this is where the evidence gets particularly compelling.
Yeah.
Generally against routine surgery, just for IVF. Multiple systematic reviews, meta-analyses, including that widely cited one by Hamdan et al., they consistently find something quite striking. Clinical pregnancy rates and live birth rates are comparable.
Comparable, whether you do the surgery or not.
Yes, comparable whether women undergo cystectomy before IVF or just proceed with the endometrioma in place. This is a critical finding. It really challenges the historical rationale for doing pre-IVF surgery solely to boost success rates.
So despite the potential reserve issues, despite worries about the cyst itself, the actual take-home baby rates end up being similar. That's huge for counseling.
Precisely. While yes, the number of retrieved oocytes might be lower in women with intact endometriomas, the overall clinical pregnancy and live birth rates don't seem to suffer. And furthermore, a very recent study, Deng et al., in 2022, looked specifically at women with diminished ovarian reserve, DOR. They found the presence of an endometrioma didn't affect their IVF outcomes. Not implantation rate, not live birth rate, not even time to live birth.
Wow, even in DOR patients.
Yes, their conclusion was pretty clear. For DOR patients, the underlying ovarian reserve status is much more critical than whether an endometrioma is present or not.
And didn't another 2022 study, Zhang et al., find something similar regarding overall outcomes?
Yes, they did. Zhang confirmed that while women with endometriomas generally had lower reserve markers in response to stimulation,
Right.
their cumulative live birth rates were comparable to controls, and importantly, regardless of whether they'd had prior ovarian surgery or not. And interestingly, even larger cysts, those 6 centimeters or bigger, didn't significantly impact cumulative live birth rates.
Even the big ones.
Even the big ones. Despite causing lower AFC, fewer oocytes, fewer embryos, their multivariate analysis pointed to age and top-quality embryos as the main drivers of live birth, not the endometrioma presence, size, or surgery history. It really shifts the focus.
Okay, so if the IVF outcomes are largely similar, are there still specific situations where surgery is strongly considered before IVF? Moving beyond just trying to improve fertility odds.
Yes, absolutely. And this distinction is critical. Surgery is still appropriate, sometimes necessary in specific cases. Think significant intractable pelvic pain that just isn't responding to medical therapy. That's a clear indication.
Right, quality of life.
Exactly. Or if there's a strong suspicion of malignancy, obviously, that needs investigation and likely intervention. And thirdly, if the endometrioma is positioned such that it technically obstructs access for oocyte retrieval, makes the procedure difficult or impossible.
Okay, technical reasons.
Right. But these are specific individualized indications. It's crucial to emphasize this isn't a routine recommendation simply to improve IVF success rates. The approach has to be tailored.
Given all this evidence pointing away from routine surgery, what are the current conservative management options, especially for infertile patients trying to preserve function?
Well, expectant management, just monitoring, is definitely an option for asymptomatic endometriomas, though it's worth remembering those single studies like Kasapoglu's, suggesting maybe a faster AMH decline over time, even with observation, needs more research, but something to keep in mind.
Okay.
Beyond that, medical therapies are being looked at more closely for their potential role in preserving reserve, although they aren't primary infertility treatments themselves. Deanagist, for example, has shown some promise. It can reduce cyst size and pain and seems to preserve ovarian reserve. One prospective study showed improved AFC and stable AMH over 6 months.
Interesting. What about others?
GnRH agonists, aromatase inhibitors, they're also being studied, but we really need more robust data specifically on ovarian reserve preservation in infertile patients undergoing RT with these medications. It's an active area.
And what about the risks during RT if you manage conservatively? Say, infection risk during retrieval or worsening endometriosis with stimulation?
The risk of complications like infection during egg retrieval, even if the needle passes through an endometrioma, seems remarkably low, around 0.6%. And this can usually be mitigated effectively with routine prophylactic antibiotics.
Okay, Mo 0.6% is low.
It is. And while there's some low-quality evidence suggesting deep invasive endometriosis might progress with stimulation, moderate evidence indicates that standard IVF and embryo transfer generally don't worsen endometriosis pain or increase recurrence risk significantly. So the risks of conservative management during RT seem generally quite low, often outweighed by the risks of surgical morbidity.
Okay, so as we wrap up this deep dive, what are the key takeaways for practitioners navigating this complex landscape? How do we manage ovarian endometriomas before ART today?
Well, the management isn't standardized, that's clear. It really demands careful, patient-specific consideration. However, the strong message from recent robust studies is that routine surgical removal before IVF is generally not indicated simply to improve IVF outcomes. Clinical pregnancy and live birth rates are consistently shown to be comparable, whether the endometrioma is resected or left in situ.
Right, that comparable outcome is key.
It is. And coupled with that, the detrimental impact of surgery on ovarian reserve, especially AMH, remains significant and appears long-lasting, even with better awareness and techniques, as that Invernicci study highlighted. So, the pendulum has really swung towards prioritizing conservative management, tailored to the individual, of course, but reserve surgery for those specific indications. Intractable pain, suspicion of malignancy, or true technical barriers to oocyte retrieval.
So it's really clear the decision resect or not before IVF is far from simple. It requires a very nuanced, patient-centered discussion, heavily prioritizing ovarian reserve unless there are compelling reasons otherwise. It feels like a significant shift in thinking.
Indeed. I think this deep dive really underscores that while endometriomas can affect reserve and response, the evidence just doesn't support routine surgery purely to boost IVF success. It forces us, quite rightly, to weigh the known risks of iatrogenic damage against what appears to be a very limited, if any, upside for fertility outcomes post-ART. The data is pretty compelling now.
A truly crucial point, especially with that recent data reinforcing the persistent impact of surgery. So for you, our listeners, perhaps the thought to leave you with is this. In light of this evolving evidence, how can we further refine our pre-IVF counseling? How do we ensure patients truly grasp this delicate balance between preserving ovarian function and fertility outcomes? And looking forward, what collaborative research might bridge the remaining gaps? How do we move beyond a simple resect or not dichotomy towards truly optimal long-term management strategies for these patients? Something to consider.